Let's start with the facial nerve. It is seventh cranial nerve. It is a mixed type of nerve which is motor to the face. It is a second arch nerve. Let's see functional components. Special visceral efferent means it will supply to do some special thing which is a visceral one, and efferent means it is motor to that thing, which are the muscles of the facial expression and the elevation of the hyoid bone. General visceral efferent means general, it will supply to general visceras. Efferent means motor. Secretomotor to submandibular, sublingual, lacrimal glands of nose, palate and pharynx. Now, general visceral afferent. Now, afferent means it's sensory. It will carry the impulses from the glands which are above mentioned. Then is special visceral efferent. It will carry some special impulses like that of taste sensation from the anterior two-thirds of the tongue. Next is general somatic afferent. Soma means body. Now it will carry the afferent impulses. Skin of ear via communication with the vagus nerve. Face proprioception via trigeminal nerve. What are the nuclei? It are motor nucleus, superior salivatory nucleus, lacrimatory nucleus, nucleus of tractus solitarius, which is gustatory. Now this both superior salivatory nucleus and lacrimatory nucleus both are parasympathetic. Now let's see the course and relations of the nerve. There are two roots, motor root and sensory root. Sensory root is also known as nervus intermedius. Both roots are attached to lateral part of lower border of pons medial to vestibulocochlear cranial nerve. Then the fibers run lateral and forwards with the vestibulocochlear nerve in the internal acoustic meatus along with the facial, vestibulocochlear and labyrinthine vessels. Let's see. We know that the meninges have outer dura, middle arachnoid and inner pia mater. In this is internal acoustic meatus. In this major part is covered by the vestibulocochlear nerve. And these are the two roots of the facial nerve. This one is bigger, one is motor and smaller one is sensory, along with the labyrinthine vessels. Now, the fibers. In fundus means bottom of the middle ear or the internal acoustic meatus. Now, the two roots fuse and lie in canal of the petrous temporal bone. Now, in the canal, the facial nerve is divided in three parts. That is, first part is laterally above the vestibule. Second part comes back above the promontory. And third part down behind the promontory. Now, after coming in the canal, it is such like that. This is the petrous temporal bone divided by the transcrest into superior vestibular area and inferior vestibular area. The superior one has the facial canal in which only facial nerve is there. Inferior one has the cochlear area. Now, after entering this facial canal, the nerve is divided into three parts by two genus. This one is external genu and this one is internal genu. Genu means what? It is a bend. Now this is first part, this is second part and this is third part. Now first part is coming laterally, which is above the vestibule. Now there is a geniculate ganglion. It is associated with the genu, therefore it's called as geniculate ganglion. Now above this promontory and between these two adductus of mastoid antrum and promontory, we will have the second part running behind. Now above promontory, it is going behind. Nerve is coming here and it's going behind. Now the second part is related with the nerve to the stapedius muscle. This we'll see in the branch and distribution again. Now there is an internal genu, that is the second bend. Now the third part will descend vertically downwards and leave the skull via the stylomastoid foramen. Now this third part is between medial wall of middle ear and posterior wall of the middle ear. This is important. If you study the middle ear, you will understand this between medial and posterior wall. Now next what comes, the facial nerve leaves the skull via the stylomastoid foramen. Now posteromedial surface of the parotid enters and runs through. Now this facial nerve, after coming out of the stylomastoid foramen, will enter through the parotid substance, that is from the posteromedial surface of the parotid. It will cross retromandibular vein and external carotid artery. Now behind the neck of the mandible, it divides and emerges along the anterior border of the parotid like the fingers of the hand. These fingers will emerge, 5 fingers to the 5 terminal branches. Let's see one by one each branch and its distribution. First, we will see the diagrammatically. This is the mesencephalic nucleus of the trigeminal, which gives the general somatic afferent fibers to the skin of the ear. Then we have the motor nucleus, which gives special visceral efferent to the terminal branches, which will supply to the facial expression muscles, along with some branches of posterior auricular branch and posterior belly of digastric branch, which also supplies the stylohyoid. Then the lacrimator and superior salivatory nuclei, both parasympathetic nuclei, are general visceral efferent. Lacrimatory and superior salivatory nucleus both are general visceral efferent. These are secretomotor to lacrimal gland, submandibular and sublingual gland, and also to the nasal palatal pharyngeal glands. Then the nucleus of tractus solitarius, which is special visceral efferent and general visceral efferent, supplies to the geniculate, means their peripheral process will relay in the geniculate ganglion, and then it will go to the tongue. Then now the fibers from this geniculate ganglion will join with the deep petrosal nerve. This is known as greater petrosal nerve. They will together form the nerve of pterygoid canal, which will relay in sphenopalatine ganglion and then supply the lacrimal gland by communicating with the zygomatic nerve. This nerve is known as lacrimal nerve. So the total pathway will be from lacrimatory nucleus, greater petrosal nerve joins deep petrosal nerve, nerve of pterygoid canal, then the lacrimal nerve, zygomatic nerve communicates to the lacrimal gland. Now the terminal branches, which are motor. One branch, they will arise just below the stylomastoid foramen from the posterior auricular branch. Then the posterior belly of digastric along with the stylohyoid. Terminal branches are temporal, zygomatic, buccal branch, marginal mandibular and cervical branch. And lingual nerve communicates with this chorda tympani branch, and it will release in the submandibular ganglion and then supply the submandibular gland and the sublingual gland. Nerve to stapedius arises from the second part of the facial nerve. Now the branches which are within the facial canal are greater petrosal nerve, this one. Then is nerve to stapedius, this one. This arises opposite to the pyramid for the stapedius muscle. And now what is the work of the stapedius muscle? It dampens the excessive vibration coming and thus protects the ear. Next is chorda tympani, this one. For submandibular and sublingual glands and anterior 2/3 of the tongue with the lingual nerve. This lingual nerve joins submandibular, sublingual and tongue, chorda tympani. Next is at the exit of the stylomastoid foramen. These are the posterior auricular branch which will supply auricularis posterior, occipitalis, intrinsic muscle of back of the auricle. Next is digastric branch which will supply the posterior belly of digastric, only posterior. Then the stylohyoid, which is branch of digastric, it will supply the stylohyoid muscle. Now these are the terminal branches. These are 5: temporal, zygomatic, buccal, marginal mandibular and cervical. Temporal branch will supply auricularis anterior and superior, intrinsic muscles on the lateral side of the ear, frontalis, orbicularis oculi and corrugator supercilii. Zygomatic will also supply orbicularis oculi. Buccal will supply buccinator. Marginal mandibular will supply the muscles of the lower lips and chin. Cervical will supply the platysma in the neck. Now there are some communicating branches with the glossopharyngeal and hypoglossal nerve. Let's see the ganglia associated. There are three ganglions: geniculate ganglion, submandibular ganglion and pterygopalatine ganglion. Geniculate ganglion is present at the first bend. It is a sensory ganglion and carries taste fibers from the tongue. Now pseudo-unipolar neurons are present in the geniculate ganglion. These are very important. Here we can see that the fibers from the nucleus of Tractus solitarius will come. Here is the geniculate ganglion, this pseudo-unipolar neuron, and its one branch will go in the tongue. Next one is the submandibular ganglion. It is a parasympathetic ganglion. It carries the secretomotor fibers for the submandibular and sublingual gland via chorda tympani node. Next is the pterygopalatine ganglion, also known as sphenopalatine ganglion. It is also parasympathetic in nature. It is secretomotor to lacrimal gland via nerve to pterygoid canal. Here you can see lacrimal gland. This is the nerve of pterygoid canal. Let's proceed to the applied anatomy. Most important with the facial nerve is the Bell's palsy. It is a paralysis of the facial nerve at the stylomastoid foramen. It causes asymmetry of corner of the mouth, this, inability to close eye, this, loss of nasolabial fold, this, there is no, here there is nasolabial fold, loss of wrinkling of skin of forehead, there is no wrinkling of the forehead. Now this is stylomastoid foramen where the facial nerve is coming, and here is the compression. It will give its terminal branches. Now there is a paralysis of upper and lower part of the facial muscle of same side, that is ipsilateral side. If the nerve of the right side is affected, there will be paralysis of the muscles of the right side. Now let's see one concept, lower motor neuron paralysis, which affects ipsilateral half face, and upper motor neuron paralysis will affect contralateral lower quadrant only, because the fibers decussate and contralateral lower quadrant receives only from the contralateral side fibers. Now the infranuclear lesion will affect the ipsilateral half face, that is motor nerve damage. It is equal to Bell's palsy. It's a half face. Now along with this, upper half face bilaterally and lower half contralaterally. Now supranuclear lesion, corticonuclear fibers are here, so contralateral lower half part will be only affected. Now the facial nerve palsy in the newborn, mastoid process is absent in the newborn. Therefore, stylomastoid foramen is superficial. Damage during delivery will cause paralysis of the facial muscle, which is buccinator, which is important for the suckling of the milk. Next is the crocodile tear syndrome. Lacrimation during eating. Crocodile tear syndrome, that is lacrimation during eating, due to aberrant regeneration after trauma, cause damage near geniculate ganglion is there. Now the regenerating fibers for the submandibular salivary gland grow in the endoneurial sheaths of the preganglionic secretomotor fibers supplying the lacrimal gland. Therefore, this submandibular salivary gland will cause salivation, and this lacrimal gland will cause lacrimation. Therefore, both are occurring simultaneously, lacrimation while eating. Here you can see. These are the fibers for if there is an injury in the geniculate ganglion. From the geniculate ganglion, the fibers pass to the lacrimal gland and also to the submandibular and sublingual gland. So, if these two, while regenerating, mingle each other, there will be both simultaneously. That is lacrimation and salivation, both simultaneously. Let's see the Ramsay-Hunt syndrome. It is a herpes zoster which involves geniculate ganglion again. It will cause hyperacusis because of stapedius muscle, as stapedius dampens the excessive vibrations. Now the nerve supplying to that is damaged, therefore there will be more heard sound for normal sound as well. There will be loss of lacrimation because lacrimal gland fibers will be affected. Loss of sensation of taste in the anterior two-thirds of the tongue, chorda tympani nerve is affected. Bell's palsy and lack of salivation because fibers for submandibular and sublingual glands are affected. Vesicles on the auricle. There will be vesicles present on the auricle. Now let's see the symptoms according to the level of injury of the nerve. If the injury is near the stylomastoid foramen, that is here, it will cause all the symptoms, that is 1 to 5 symptoms is mentioned. First I'll read the symptoms. Loss of lacrimation, loss of stapedial reflex, loss of taste from the anterior two-thirds of the tongue, and loss of salivation and Bell's palsy. Now if there is here, all the branches will be affected. So all the functions which are done, that is lacrimation by the greater petrosal nerve, nerve to stapedius, the stapedius reflex will be lost, chorda tympani, taste from the anterior two-thirds tongue lost, then loss of salivation from this submandibular and sublingual gland. There will be Bell's palsy, of course, terminal branches will not supply the facial muscles. Now, if the injury is below the geniculate ganglion, leaving the greater petrosal nerve, here is the injury, greater petrosal nerve will not be affected and lacrimation will be normal. All the rest will be there. Now, if the lesion is below the nerve to stapedius, this both will be ruled out. Therefore, lacrimation and hyperacusis, lacrimation will occur and hyperacusis will not occur. That is, stapedius will do its work. Below will be affected. Now, if the damage is below the stylomastoid foramen, only Bell's palsy will occur because only the terminal branches supplying the facial muscles will be affected.